Welcome to your renal posting survival guide. In this explainer, we're jumping right into one of the most critical procedures you'll manage, hemodialysis, or HD. To make this really practical, we're going to walk through a classic case, the kind you're almost guaranteed to see in your very first week.
So let's set the scene. It's your first day on the ward. A patient with known chronic kidney disease, CKD, gets sent in. They're struggling to breathe, their legs are swollen, and their potassium is dangerously high. This is a full-blown renal emergency. You know they need dialysis, but what exactly happens next?
So, let's meet Mr. Lim. His kidneys have gotten to the point where they just can't clear out toxins or excess fluid anymore. He's got all the classic signs of uremia, and that hyperkalemia, that's a huge risk for a life-threatening arrhythmia. The decision here is crystal clear and it's urgent. He needs hemodialysis, like right now, and your job is to make that happen safely and effectively. Okay, so the whole thing really starts on the computer. Before Mr. Lim even gets to the dialysis unit, you have to place the order in our Epic system. And this isn't just some administrative task. This is where you, as the doctor, set the entire prescription for his treatment. This is really where your clinical judgment kicks in. See, ordering dialysis for the very first time is a totally different ballgame than ordering it for a stable, long-term patient. So what are the absolute must-know, essential parameters you need to get right for Mr. Lim's first and very urgent session? All right, this table basically breaks down those key fields on your order screen. For a first-timer like Mr. Lim, look at the time. We're going to keep it short, just 2 or 3 hours. This is super important to prevent something called dialysis disequilibrium syndrome. Next, your ultrafiltration, or UF goal. That's just how much fluid you want to pull off. The dialysator is chosen based on weight, so most adults will get the Polyflux 170H. For anticoagulation, we'll start with low-dose heparin, assuming, of course, there are no major bleeding risks. And this next one is absolutely critical, the dialysate potassium. We set it to 2. This creates a gradient to pull potassium from his blood, but we avoid a massive sudden drop that could trigger an arrhythmia. So, you've placed the order, Mr. Lim is all hooked up, and the machine is running. What is actually happening to his blood as it's circulating through that dialyzer? What are the fundamental principles at play here? You know, this whole process really boils down to 3 core principles. First up is diffusion. All those uremic toxins move from the high concentration in the blood into the clean dialysate. Simple as that. Second, ultrafiltration. This is basically the pressure that squeezes excess water out of the blood, which treats his fluid overload. And finally, convection. As that water gets pulled out, it actually drags even more waste products along with it. Pretty amazing, right? These are simple principles with life-saving results. Okay, an hour into the session, you get that call from the dialysis nurse. And this is probably the single most common complication you're going to manage on your rotation, intradialytic hypotension, or IDH. Basically, the patient's blood pressure just plummets during treatment. His blood pressure has absolutely tanked. He's feeling dizzy, a little nauseous. This is one of those critical moments that requires you to act fast and, more importantly, systematically. You're called to the bedside. What are your immediate steps? This is your rapid response protocol. First thing you do, tell the nurse to stop or slow the ultrafiltration. Just stop pulling off fluid. Second, get the foot of the bed up, put him in the Trendelenburg position. Third, give a bolus of IV normal saline. Now, while that's running, you're doing a quick assessment. Are there any other causes, like an arrhythmia? If he's still hypotensive, you can reduce the blood and dialysate flow rates. And if nothing works, your final safety net is to just stop the session. Responding in the moment is absolutely key. But the real goal here is to prevent it from happening again. And that means thinking about chronic strategies. You know, the most common reason for IDH is that the patient's target dry weight is set just a little too low. We can also try making the dialysate cooler, or maybe increase the calcium in it. Both of those things help support blood pressure. These are the adjustments you're going to discuss with the team for Mr. Lim's next session. So, Mr. Lim's urgent dialysis was done through a temporary catheter placed in a large vein. This was totally necessary for the emergency, but it brings us to what is arguably the most important long-term factor for any dialysis patient, their vascular access. It is truly their lifeline. I mean, look at this number, it's staggering. Here at KTPH, a full 80% of our patients start dialysis through a catheter. Now, while that's often unavoidable for urgent starts, it really highlights a key goal for your posting, identifying patients who need dialysis before it's an emergency so we can get them better, safer, permanent access. This slide really shows the essential trade-off in vascular access. A tunneled catheter, yeah, you can use it right away, but it carries a high risk of infection and is tied to worse long-term outcomes. In contrast, an arteriovenous fistula, or AVF, where a surgeon connects an artery directly to a vein, that's the gold standard. It has a much lower infection risk and can last for years and years, which leads to better survival. The only catch? It needs time to mature.
So the crucial point here is this. Until Mr. Lim gets that fistula, his catheter is his biggest vulnerability. This quote should basically be your mantra. Any patient with a catheter who spikes a fever, you must investigate for a catheter-related infection. It's a line infection until you can prove it's not.
Okay, so we followed Mr. Lim's journey from his emergency admission through prescribing his first HD session, all the way to managing a common complication. Let's wrap this up by distilling everything down into the essential takeaways for your renal posting. This is your survival kit. First, always check the dry weight. And for new starts, go low and slow with a shorter session. Second, you need to know that IDH management protocol by heart. Third, remember, fever plus a catheter means you have to investigate for line sepsis. And finally, always be thinking ahead and advocate for an early AV fistula referral. And that brings us right to our final thought. You've successfully managed Mr. Lim's acute crisis, but our job doesn't end there. Probably the most important conversation you can have now is about his future on dialysis, a conversation that really centers on securing the best possible lifeline for the long road ahead.